I'm Dr. Petrović. I come from Sciences-Serbian company in Serbia. It's my great pleasure to be here, and I would like to thank the organizer who invited me and this great meeting. Well, my task today is talk about treatment acute heart failure in pre-hospital settings and emergency department. It's such sometimes difference what we should to do in the, especially in the pre-hospital, in the emergency department, or we should to do in the hospital settings. As we know, acute heart failure is an urgent condition which requires urgent IV treatment and urgent management. Nowadays, heart failure has epidemic course, which has high mortality over the 5 years, about 50%, and that course is interrupted with hospitalization due to acute heart failure symptoms, because it has influence on that worse prognosis, and because the adequate and early treatment is very important of acute heart failure patient. Acute heart failure consists of the 4 clinical entities, as we know: acute decompensated heart failure, acute pulmonary edema, isolated right ventricle failure, and cardiogenic shock. I talk about every this item separately about early treatment. Early diagnosis of acute heart failure means that we can perform ECG, chest X-ray, lung ultrasound, echo, natriuretic peptides, serum troponin, serum creatinine. Many of them tools we can perform and recommended to perform in the admission to the emergency department, some in the pre-hospital settings like echo, for example, and ECG also. And when we established diagnosis, then we decided to perform triage. That's what we do with that patient. Then sent to the ICU or CCU or ward, or discharged from the emergency department. We have a critical patient with respiratory insufficiency, hemodynamic insufficiency, renal function is not good, ACS is here. That patient we admitted in the ICU or CCU on level 1 to level 3. But if our patient is respond to the initial therapy with good hemodynamic respiratory condition, ACS was excluded, renal function is okay, that patient we can discharge directly from the emergency department. Main treatment of the acute heart failure patient means to treat congestion or hypoperfusion and treat specific or factors which cause the acute heart failure symptoms. Acute pulmonary edema, initial therapy means to perform oxygen therapy, or if we need non-invasive or invasive ventilation, and perform loop diuretics as early as possible. If it has signs of hypoperfusion, we need to perform pharmacologic circulatory support like vasopressor stimulation. If patients don't respond to that therapy, we need for escalated therapy with renal replacement therapy, MCS, and etc. Indication for oxygen therapy is that saturation of oxygen below 90%, and if respiratory failure is progressive, then we need for non-invasive or invasive ventilation of patient with intubation. Management of acute decompensated heart failure is similar to treatment of acute pulmonary edema, on oxygen, loop diuretics, and vasopressor suppression, and escalation or de-escalation therapy depends on responding to patient on that initial therapy. It's questionable what is the ideal time to perform diuretic or loop diuretic treatment and vasoactive agents. This year we published several papers with small studies. We generally concluded that you should perform your diuretic therapy with loop diuretic as soon as possible, but not that means that you should perform in the pre-hospital setting, that they perform in the emergency department, and that lead to improve in hospital and after discharge outcome. In the vasoactive agents of nitroglycerin, which often used in the treatment of the acute heart failure patient. It is good to perform IV infusion in the pre-hospital setting, and that leads to better outcome in hospital and post-discharge. In the past, all of us use morphine as often to treatment in the acute pulmonary edema special patient, but nowadays guidelines not yet recommend to routinely use morphine because it has serious adverse events, and if we need to sedate it, our patient, better to use the midazolam than morphine in that situation. This year is published one study also in the New England Journal of Medicine and the ACS Congress this year, 8-hour study, which investigated acetylazamide in treatment in the acute heart failure patient, and the result of the study shows us that is better decongestion in the acetylazamide group than in the placebo. If in the right ventricular isolated dysfunction, we first must to optimize fluid status of that patient and carefully administer the loop diuretics because of hemodynamic compromise in that situation. And other side, we can treat a specific the factors who cause the right ventricular failure. Also, if patient didn't respond to that initial therapy, we need to perform vasopressor stimulation and other therapy with renal replacement therapy and mechanical circulatory support. The treatment of cardiogenic shock, initial treatment means that ventilatory support with non-invasive or invasive ventilation, perform pharmacological circulatory support with the vasopressor stimulation, or short-term the mechanical circulatory support. In the next session, we have next session with about cardiogenic shock, where they talk about detail of these items. Time is important, like other in cardiology, and this is a time flow chart when we should to perform any treatment and measurement of acute heart failure patient. In the first 10 to 15 minutes, we need to establish diagnosis and start initial treatment. From that to 3 hours, we must to treat the specific factors who cause the acute heart failure, and the reassessment of the clinical condition of patient, and according to that, we need to escalate it or de-escalate the therapy. General overload to treatment, early treatment of acute heart failure means early diagnosis, early decongestion or vasoactive therapy, goal-directed therapy initiation, and safe transition of care. And at the end, we can conclude it, and some kinds of take-home message is that early treatment of the acute heart failure means oxygen therapy, loop diuretic, as soon as possible in the emergency department, nitrates in the pre-hospital settings, vasopressor stimulation if we have the signs of hypoperfusion, and specific treatment like, for example, revascularization for ACS, bridge to decision, MCS, and etc. Thank you for attention.